To talk on this recent editorial that we published in Anaesthesia, which is commenting on a paper in the same issue looking at frailty assessment prior to surgery. And it's also looking more widely at the issue of how best to support more frail patients during their perioperative care. So I'm Adam, I'm an ST6 anaesthetist in London, and I'm about to start a PhD looking at the impact of deprivation on outcomes after major surgery. And I will let Rose introduce herself now.
So I'm a registrar in geriatric medicine, currently based at the University of Edinburgh, where I'm doing a Wellcome Trust PhD looking at multimorbidity and delirium in acutely hospitalised older adults, including acutely hospitalised surgical populations. Unfortunately, I'm in wet and windy Scotland today and not in Athens, but very nice to join you all.
So I'm going to start by discussing the background to this paper as well as outlining the study itself. So focusing on how the authors conceptualised perioperative risk. I'll summarise the major findings, and then I'll hand over to Rose, who's going to discuss frailty in the wider context from the perspective of a physician regularly looking after older patients, as well as some practical takeaways. So as background, it's worth acknowledging that frailty is very common in the anaesthetic workload, especially as patients get older. And this was highlighted by the activity report from the recent NAP7 survey. So patients over the age of 65 made up almost 50% of cases performed during that survey period. And frail older patients, that is those over the age of 65, with higher clinical frailty scores, are overrepresented in anaesthetic complications. So that small cohort contributing around 20% of the cases of perioperative cardiac arrest in NAP7, for example. Frailty itself can be defined in a couple of different ways. So the Fried phenotypic model of frailty on the left considers it as a clinical syndrome that presents with a number of key traits. These are defined as unintentional weight loss, low physical activity, weakness or poor hand grip strength, slow walking speed, and self-reported exhaustion. And so if at least 3 of these traits are present, this is indicative of frailty. In contrast, the frailty index on the right, which was originally described by Rockwood, defines frailty as a consequence of interacting physical, psychological, and social factors. And these may commonly be evaluated, for example, using a comprehensive geriatric assessment. As these deficits accumulate, people become increasingly vulnerable to adverse outcomes. And so the number of deficits a patient may have then is divided by the total number of deficits considered by a particular score to provide a scale or ratio from 0 to 1. Both these approaches are totally valid, but it's important for studies on frailty to be clear as to their approach for defining frailty, and as Rose will come to talk about how it is quantified. This has significant implications for comparisons between groups and how these patients are managed. So the study that Rose and I were invited to discuss was by an American research group from Harvard Medical School, led by Dae-Hyun Kim. It drew on data from insurance claims made within the American Medicare system. So for those who are less familiar with US healthcare, Medicare is a form of government-funded health insurance, which is available to the majority of individuals over the age of 65. So by definition, this is a cohort of older adults. They use the information provided with these claims to estimate the level of frailty, and therefore it's somewhat analogous to a frailty index. They also assessed how major the surgical intervention was, and when they were then able to use follow-up data to look at perioperative outcomes. So we're looking at a retrospective study, which is purely observational, and it took as its principal outcomes mortality, both within 30 and 365 days, readmission to hospital, and a measure called time spent at home, which is quite important in this context, and Rose will talk in a little bit more detail about the significance of this measure later on. So before it seems like we're going off on a tangent too far removed from daily anaesthetic practice, we can think of what is being assessed here as overall perioperative risk. It could be said that at a basic level, the risk a patient encounters when undergoing surgery is the product of their baseline health, which would commonly be assessed through pre-assessment, and which might other settings be described, for example, using the ASA score, and how invasive the surgical procedure is. So in this study, the baseline, sorry, next slide, please, Rose. The baseline health approximates to the frailty index, which is derived from the Medicare claims data. And then surgical stress was categorized as something that the authors referred to as the operative severity score. So I won't bore you with the details of exactly how the OSS is calculated, but essentially the higher the OSS score, the more major the surgery is. So you could consider it as being analogous to the sort of minor, major, complex, major classification that we'd be familiar with. So let's move on to look at some of the findings. Much of the results are pretty unsurprising. So here we're looking at 30-day mortality and how it varies both by operative severity score and within each of those operative severity score categories by frailty. And as you expect, for a given level of surgical stress, there's an increase in mortality as patients become more frail. That's firstly straightforward. However, the results for how mortality at 1 month changes as the level of surgical stress increases are more complex and maybe a little bit counterintuitive. So for most categories, these are very large numbers with the possible exception of the highest category of surgical stress. And we can be reasonably confident, therefore, that these are real differences that we're seeing. But the distribution of mortality appears to be bimodal. So you can see that it peaks in the second lowest and the second highest categories. This is purely an observational study, and it would be useful to perform regression analysis to adjust for frailty in looking at the proportion of patients undergoing surgery at each level of surgical risk. But we've theorized that the reason for this bimodal distribution of risk is likely to be an interaction between frailty and surgical risk taking, which is to say patients who are more frail are less likely to undergo more invasive surgical procedures. We therefore see them potentially contributing to an excess of mortality for more minor surgical procedures. So these data could be seen as evidence of shared decision-making in action, but as Rose will talk about shortly, for these decisions to be truly informed, the timing and accuracy of assessing frailty is key. It's worth saying that the authors also report similar results for mortality at 1 year, as well as for risk of readmission. So before we go on to place these findings more in the context of which we practice here in the UK, we'll look at a few of the key takeaways. First, and unsurprisingly, frailty strongly predicts the risk of major complications, such as death and readmission to hospital following surgery. Second, the risk appears to increase independently as the relative level of invasiveness increases, which underlines the importance of shared decision-making and the potential for robust frailty assessment to contribute to that process. Neither of these findings are particularly groundbreaking, I'd argue. However, in terms of planning post-operative care for older adults, there was one particularly interesting finding. And that was that in all the patients included in this study, there was a predicted risk of mortality greater than 1%, which is what this little excerpt from the paper is saying there. And the significance of this is that CPOC guidelines recommend EPC for all patients with predicted mortality risk within 32 days of surgery of greater than 1%. So that may be any form of enhanced perioperative care, be that overnight intensive recovery, post-anaesthetic care, surgical HDU at level 1, and this is before considering other contextual factors such as the specific procedure taking place. So given that CPOC guidelines recommend enhanced perioperative care for all these patients, it suggests there's a significant unmet need for EPC facilities for such patients. In fact, it questions altogether whether any procedure is truly low risk in frail older adults. And with that, I'm going to hand over to Rose.
Thanks very much, Adam. So I think, as Adam's kind of already alluded to, I think it's fairly safe to say that there are differences between the US and the UK context. And I think in terms of kind of thinking about comprehensive care for frail older adults throughout the perioperative pathway, I think in some ways we're actually ahead here in the UK. So I show here some guidelines from the Centre for Perioperative Care, co-written with the British Geriatric Society. So these are perioperative pathway guidelines for people living with frailty who are undergoing surgery. So they emphasize a number of things, and importantly, a whole pathway approach and the importance of shared decision making with the patient and their family, with a clear understanding of the different options that are available. One of those options, of course, being no surgery. So these guidelines make a number of key recommendations, and it's not possible to summarise all of these here. However, some of the key recommendations include the fact that all patients aged 65 years and above who are referred for surgery should have their initial frailty status documented using the clinical frailty scale, and I'll come on to that in a minute. Those patients who are identified as frail by the CFS should then have a comprehensive geriatric assessment performed by someone who's appropriately qualified and experienced, as well as a cognitive assessment, and that's my area of particular interest. The NAP7 report sort of agrees with many of these recommendations and also suggests that treatment escalation plans, including resuscitation status, should be discussed and clearly documented for all patients. Now, early frailty identification is very important, as it not only guides prognostication, but also means that any potential complications following the surgery can be anticipated and hopefully mitigated by multidisciplinary teams. So, mentioned the CFS. Some of you may already be familiar with this. So the clinical frailty scale is a 9-point scale developed based on a frailty index approach by Rockwood and colleagues in Canada. Although I should note that a CFS of 9 refers to those who are approaching the end of life within 6 months of end of life. So technically, a CFS score of 8 is the most severely frail patient. So in research studies, the CFS has shown good agreement with other frailty scales in surgical populations, and it's also associated with important adverse outcomes, including mortality. I think very importantly for this context, it's also a very straightforward and quite pragmatic scale, and there's minimal training required for its effective use in clinical settings. However, there are additional resources available on the Dalhousie University website that can assist with accurate scoring. I think as a geriatrician, something I often see when the CFS is used in practice is that it's applied at the point of care. And actually, we should be assessing patients based on their baseline frailty status, i.e. thinking, what was this patient like 2 weeks ago before they came into hospital and acutely unwell? However, we are taught very early in medicine that there's really no point in performing an assessment or investigation if it's not going to change your management. And an issue with the Park et al. Study that we've been discussing is that it actually uses a retrospectively derived frailty score. So really, unless this is available to clinicians at the point of care, it can't really be used to inform management. Now, I often hear from people in various specialties that there's nothing that can be done about frailty. However, I think there's accumulating evidence to suggest otherwise. I present here a recent quality improvement study of over 50,000 patients, again performed in the US. Varley and colleagues linked a standardized preoperative frailty assessment to an electronic patient record alert, alerting clinicians that this patient was frail or most frail. And in this study, they reported that implementation of this linked alert led to a reduction in post-operative mortality from 3.9 to 3.3%. And the greatest mortality benefits were actually seen in those people who were identified as most frail. Now, if you read the paper, they speculated on a few reasons for this, and I think we probably can too. So potentially identifying people with frailty early in the perioperative pathway could lead to identification of modifiable risk factors, and there's some evidence to suggest that frailty is partially reversible. It also means that, together with discussing with the patient and family, can opt for a surgical procedure that perhaps has a lower operative stress score. And obviously, it enables early comprehensive geriatric assessment and involvement of geriatricians throughout the care pathway. So again, this is something that we've actually been doing for some years now in the UK, with increasing adoption of a perioperative care model, so POPS model, perioperative care for older people undergoing surgery. So as part of this model, geriatricians are integrated throughout the perioperative care pathway. And in studies, it's been shown to improve outcomes, including post-operative complications and length of stay. However, of course, the success of the perioperative model depends, of course, on funding, resources, and the local context for implementation. I wanted to highlight here that there's actually ongoing work at the moment led by Professor Desi, who's based at King's College London and was a pioneer of initial POPS models in the UK. Called the POPS Up study, which is aiming to scale up and roll out POPS services across the UK. So if this is something that you're interested in, definitely listen out for that, as I know that they'll be looking for centres as part of that multi-centre study. Now, we've talked here a lot about studies that have looked at mortality and other outcomes that are available from routine data. And yes, all of these metrics are very readily accessible. But are these things that actually matter to patients? I wanted to highlight here that in the Park et al. Study, they actually report not just on mortality, but also on another metric, which is home time. So home time is the number of days that a patient spends alive and at home following their surgical procedure, often in a given time period, for example, a year. It's inherently a composite metric in that it really combines information on the patient's discharge destination, whether they're readmitted to hospital, and of course, death. And actually, the home time metric has been validated in several different surgical populations, and qualitative studies have suggested that this is a metric that actually really matters to patients. People want to go home and live at home following their surgery. So This is all very well, and we're talking about how important frailty assessment is at the front door and embedding comprehensive care throughout the perioperative care pathway. However, this all begs the question. We know that early frailty identification using a validated tool can influence management and it can improve outcomes. So why aren't we doing this already? I think a number of potential barriers have been identified. So firstly, there's a multitude of frailty assessments. We've talked here about CFI, which is derived from routine data, the CFS, the clinical frailty score, which is a short assessment tool that can be performed by clinicians on initial assessment. But actually, this can be overwhelming. And perhaps if we had greater consensus and standardization, this might lead to greater adoption of routine frailty assessment. Of course, I think many of you on the call will be working clinically, and frailty assessment and the care that necessitates adds to our workload. And there's perceived time and effort to complete the assessment, and particularly to act on it. Frailty status is often poorly documented, and even though many people may have had a frailty assessment performed in the community and primary care, that information is not always transferred to secondary care, or actually is very rarely transferred to secondary care. Of course, something like the POPs model requires significant funding and a skilled workforce in order to deliver it effectively. And we need to think about the feasibility of implementing some of these guidelines, the CPOP BGS guidelines or the POPs model, in less resource-rich settings, i.e. this is something that should be available to patients across the UK, and I'd argue further afield as well. And of course, all of these things require training and education in order to deliver them effectively. I talked earlier about the fact the CFS is a brief and fairly straightforward assessment tool, but it does still require some training and education in order to implement it effectively. And certainly to deliver comprehensive perioperative care requires a significant amount of training and education. So I think in summary, we can see from this paper that frailty assessment is possible at scale in surgical populations. And it can be done using routinely available data, available from the patient record, or using a straightforward tool, for example, the clinical frailty scale, which can be delivered by a wide range of clinicians with fairly minimal training. I think we already know, but we see again in this study, that frailty is associated with significant adverse outcomes, including mortality and also reduced time at home in the year following surgery. I'd argue that all older adults should have a frailty assessment performed as part of the perioperative pathway, and that this should be used to inform their care, to inform decision-making regarding surgery and management, with always having an option for a lower risk surgical procedure or not for surgery at all. Now, we already have some very good guidelines in the UK, so the CPOC and BGS guidelines that I've talked about. We have POPs models in some places and enhanced perioperative care. But these are not universal, and there are many barriers to their effective implementation, including, of course, funding and staffing, a universal problem at the moment. So I think this study raises several outstanding questions, and I'm sure that people can think of others too. So I think the first thing is, how do we ensure that all patients receive frailty assessment and that this is performed in a systematic way? How do we ensure that frailty information is available to clinicians at the point of care, rather than, for example, through a retrospectively derived frailty score? Having identified frailty, what aspects of the perioperative care pathway can we actually modify? And does routine frailty assessment and a whole pathway approach actually improve outcomes? And importantly, we need to think about those outcomes that actually matter to patients, rather than those that we can easily obtain from our routine data. I'd just like to say thank you very much for inviting us both to speak today. I've got some references here, so reference QR code to our editorial and to the original paper that we discussed, as well as to the BGS and CPOC guidelines that we talked about today.